And if you feel comfortable turning on your videos, I always say I appreciate it. So I'm not just sitting here staring into the black abyss. I also understand if people don't feel comfortable. So follow your own comfort level here. I'm just going to give it a couple more minutes and see if any other latecomers are coming on. Of course, we'll record this video for the website so people can access it after the lecture. If I could just get a quick sound check, if somebody that's here could either send me a message or just say hello if they can hear me, that'd be great. Thumbs up. All right, thank you. I appreciate you guys being here on a sunny afternoon. If you're here in northern Idaho, it's sunny here, which has been rare lately. And the next thing I'm going to do here is I'm going to share my screen. And if you can see this PowerPoint, again, if somebody could just say, yeah, we see it, or shoot me a thumbs up. All right, thank you. My thumbs up buddy here. All right, so I'm going to go ahead and get started so we can get going on time and finish on time and everybody can get on with their day. Like I said, I appreciate anybody who has joined us today live. I thoroughly encourage participation, questions, clarifications, anything that you have going on here. It's really helpful, again, for me as a lecturer to have that integration, of course, not mandatory. So we're going to start off. We're talking today about all things iron. And before I want to get started here, the impetus for even bringing this topic up was really just clinical experience. I have been seeing so often lately, patient labs coming back without an iron panel being run, maybe just a ferritin, maybe just an iron standalone, and actually finding and diagnosing pretty severe anemia or a genetic condition called hemochromatosis. So I find myself talking about this a lot in patient visits, and wanted to put something out there that gave a broader overview of why iron is important, how we even obtain iron, and then how we treat when we have conditions that either have less iron or low iron or too much iron. So that's really why this came to be. I'm gonna move this PowerPoint to be a little bit bigger. Again, hopefully everybody can see that okay. And we're going to talk about iron. So first and foremost, what is it? Iron is a mineral. It's one of the most abundant minerals on the earth, and it's essential for maintaining our healthy blood. That's the first thing we think of when we think of iron. It's part of our hemoglobin molecule, which is the protein in our red blood cells that carries oxygen from the lungs to all parts of the body. So right off the bat, we know that this is essential for life. It's also part of myoglobin, which is a protein that is in our muscles that carries and stores the oxygen in our musculature that allows for that functionality there. It also serves very many metabolic processes in the humans, including DNA, RNA synthesis, and in the electron transport chain, which is responsible for making the energy in the form of ATP that we experience every day. So there are two different forms of iron in the body. I just want to make sure, is this chat window, can everybody see that, me moving it around, or is that just on my screen? If somebody can answer just really quick, because I want to make sure that that's not blocking the view of the PowerPoint. It looks okay, so you can just see the PowerPoint. Great, thank you. Okay, so there's two forms of iron, and this is a big a topic that we talk about a lot. There's heme iron that comes from animal flesh, meat, poultry, and seafood. And that's it. It's the most absorbable form of iron that we have. So when I have somebody who is anemic, and we'll talk about, risk factor groups later, when we're prescribing iron and we want to get iron into the system, then we're going to lean more towards heme sources. It's still absorbed only at about a rate of 30% when we intake that from our diet, whereas non-heme iron is absorbed between 10 to 20% in the small intestine. And non-heme iron is found in our iron-rich non-animal foods, the whole grains, nuts, seeds, legumes, leafy greens, fortified foods like cereals, and then of course it's also found in animal flesh. How do we get iron into our system? Don't worry, I'm not going to go through this whole biochemistry picture over here, but unlike other minerals, we only get iron by what we absorb, and it's absorbed in the small intestine. So right off the bat, you have to think if there's any GI disorders, any inflammation, any dysbiosis, cancer, then those are going to inhibit our ability to absorb iron in the small intestine, and that's in the duodenum and the jejunum. Things that enhance the absorption of iron is vitamin C or citrus and heme iron. So if we're trying to absorb non-heme iron, then the best way to get that in our system is actually to also take in heme iron. Things that inhibit absorption are bran fiber, calcium in the form of supplements, plant substances like phytates and tannins, black tea, and soy protein. Also, some medications like proton pump inhibitors can actually inhibit the absorption of iron because iron needs an acidic environment to be absorbed in the small intestine. And of course, if we're blocking acid in our stomach, then we're not promoting that low value that is going to enable iron absorption. Before we go much farther, we just have another joiner here. Chat works great. If you guys have questions, just always send them on chat. You can also raise your hand through the button there, and that'll show up that you have a question. And again, I encourage full participation. So you can just unmute yourself and ask a question if that feels more comfortable. How do we lose iron from our system? Sweat, shedding skin cells, menstruation, GI loss through the feces. And then of course, menstruation kind of covers it, but any sort of blood loss is a way that we're going to, of course, lose iron from our system. Ferritin, this is a question I get very often, is what is ferritin? We'll run a ferritin lab when we're checking iron panel. Ferritin is often misunderstood as only the storage site for iron, although it is a very large protein in the body that does store iron and release it in a controlled fashion based on what the body needs are. It is also what we call an acute phase reactant, and it's a protein that's made by the liver in response to inflammation. So we can have an elevated ferritin with normal iron levels. We can also have a decreased ferritin level with normal iron levels. And when ferritin is decreased, it can be an early sign of iron deficiency anemia. And what I tell people often is think of your checking account and your savings account. It's as if somebody is pulling money out of your savings account while you're still getting paid. So there's still iron coming into the system and being used by the system, but that savings account is being run dry. So we don't have those stores anymore. And if there's anything that affects that absorption and use of iron in the checking account, then you're going to start having these symptoms of anemia. It can also be decreased with liver disease and in pregnancy. Ferritin is increased when we have too much iron overload, which also a genetic form of iron overload is hemochromatosis, as you see on the sign there on the slide. It also can be increased with alcohol, anemia of chronic disease, which would mean you would have normal iron levels, but there would be higher inflammation levels, chronic inflammatory diseases, including autoimmune conditions, hyperthyroid, and thalassemia. Are there any questions on ferritin? Okay, we're going to get into the weeds here just for a minute about some more biochemistry. Again, because I think it's really important that when you look at your labs, you understand what it is you're looking at. So some other lab values related to iron include transferrin. Transferrin is the transport protein for iron to be carried through the bloodstream. The liver, again, is the main source for manufacturing transferrin. It's up and down regulated based on our need for iron. And it delivers iron from absorption centers in the small intestine and enterocytes to all the tissues in the system. So it's essentially carrying the iron from the small intestine to the tissues that need it. The total iron binding capacity is the total amount of iron that can be bound to transferrin. That's the blood's capacity to bind iron with transferrin. Now, if all this sounds really, really heady and cerebral, don't worry, I have a really good metaphor coming up. The transferrin saturation, again, is the ratio of the serum iron and total iron binding capacity times 100. So this shows of the transferrin that's available, how much is actually bound. As promised, here's the metaphor. Think of iron transport system like a school bus. If transferrin is the protein that carries iron, then think of that as the seats, the actual physical seat that's able to carry iron. Iron is the school kids trying to get on the bus. The total iron binding capacity over here is how many seats are on the bus, how many seats are available for iron to be bound to. And then the transferrin saturation over here is how many iron are actually bound to the transferrin on the bus. Again, if anybody has any questions, go ahead and let me know. If you don't, please mute your microphone. I am hearing a little bit of background noise here.
Oh my gosh, you took down the whole thing.
You just trimmed it up so it's not a thing.
There we go. Okay. So we're going to back it up one more step from the school bus analogy. If the kids are the iron, right, trying to get on the school bus, and we know the seats are going to carry it, which is the transferrin, then we're going to call ferroportin the bus door. Ferroportin is located in the enterocyte or the intestinal cell, and it regulates whether iron is released into the circulation or whether the kids can get onto the bus. So it's literally kind of the bouncer that says, hey, can iron come out of this enterocyte into the circulation? Hepcidin is also an acute phase reactant similar to ferritin that's made primarily in the liver. Also, hepcidin then is what I would say is the bus driver. Hepcidin is responsible for whether or not ferroportin will release iron into the bloodstream or not. And if we're making more hepcidin in an inflammatory condition or with high iron levels, then it's actually going to bind to that ferroportin and prevent absorption, which means it stays in the small intestine and gets excreted, and we'll have less iron in the blood. If hepcidin is decreased, then we're actually going to allow that ferroportin to release iron from the small intestine cell, bind to the transferrin or sit in the seat and circulate in the bloodstream. So it's an inverse relationship there. If we have increased hepcidin, then we're actually going to have decreased absorption of iron. And we're going to come back to this concept when we talk about iron overload here. Does anyone have any questions on those kind of biochemical concepts of how we get iron in the system, and not just how we get it into our body, but also how it then gets absorbed through the small intestine? Okay, so now we're going to talk about iron deficiency. Iron deficiency affects a large proportion of the world's population. The people at high risk are females of childbearing age, children, and individuals living in low and middle income countries. The major causes of iron deficiency are decreased dietary intake, reduced absorption, or blood loss. It could be overt via traumatic hemorrhage, vomiting blood, having heavy menstrual cycles, having blood in your stool, coughing up blood, having blood in your urine, or pregnancy and delivery. Occult blood can also cause iron deficiency anemia if you are giving blood frequently, if there's a physician who's making you undergo excessive lab testing, if there's an underestimation of how heavy your menstrual cycle it might be, pregnancy and lactation, and GI bleeds, either from gastritis, malignancy, parasites, ulcers. There's many reasons that the GI could be losing blood. So those are some of the ways that we actually are becoming anemic. What I want to hit on just for a moment here, because in lieu of a decreased dietary intake, which is actually quite rare in America, you know, in not a third world country, if people have access to foods, dietary intake, unless you're part of an at-risk population, we'll talk about in a moment, like vegan or vegetarian, isn't really that known to be causing a decrease in iron. Same goes for a blood loss, right? If it's overt, we're obviously going to talk whether you're a heavy menstruating female, if you are breastfeeding, if you are doing phlebotomy or donating blood often, then we're going to know that you could have a risk for anemia. But one that rarely gets covered, I think, is reduced absorption. And that's essentially saying, hey, is there something going on in the small intestine where iron should be absorbed? So we're eating enough. We don't have a bleed, but we're still not getting enough in our system. And some of the conditions that degrade the mucosa of the duodenum are celiac disease, tropical sprue, Crohn's disease, duodenal cancer, duodenal ulcers, and familial adenomatous polyposis. So that's just some of the conditions. What I will also add to that list, and something that we see really often here, is something called dysbiosis. It's an imbalance of the microbiome in the GI tract that will cause reduced absorption rates because of inflammation in the small intestine. So this is a piece, again, in maybe the conventional world that I'm seeing being missed, and not just with iron, but many nutrients. Hey, I'm eating a well-diverse diet, but I'm having these symptoms of nutrient deficiency, and my labs are showing up as such. Going on to symptoms of iron deficiency, they're somewhat vague and very broad. Unexplained fatigue, lightheadedness, depression, rapid heart rate or heart palpitations, pale or yellow colored skin, shortness of breath, weakness, headaches, restless leg syndrome, poor focus, hair loss, chest pain, cold hands and feet, brittle nails, nausea, loss of appetite, confusion or cognitive changes, sore muscles, apathy, pica, which is the craving for ice chips, chalk, or other types of food that people can undergo with these deficiencies, exercise intolerance, or red and pink urine. Again, really broad, lots of different things that could be showing an iron deficiency, and that also can mimic a lot of other conditions. The populations at highest risk for iron deficiency: pregnant or menstruating women, children because of their growth rate requiring more iron needs, the elderly because of a lower absorption status, vegetarian and vegan diets, endurance athletes, and people with chronic kidney failure who are on dialysis. The stages of iron deficiency anemia, first of all, again, we talked about ferritin. The iron stores will deplete. So those ferritin, that savings account, can be totally deplete without showing anemia, frank anemia on your lab test, which is why running a ferritin with your iron panel is so important. There's still enough iron in the blood available for hemoglobin synthesis, but you may start having a patient who's presenting with symptoms like fatigue or decreased exercise tolerance. As those are deplete and the iron levels start to deplete, then you'll show the symptoms that we just talked about. The basic labs will show anemia. And then there's compensatory mechanisms in the body: increased in erythropoietin, which happens at the kidney, and decrease in hepcidin. Like we talked about before, if the hepcidin decreases, then the ferroportin is allowed to take that iron out of the small intestinal cell and allow it to bind to the transferrin in the bloodstream to be circulated. I wanted to show you what an example of some labs of anemia may look like. Of course, this is a very severe case, but you can see right off the bat, we'll start here at iron. Iron is low, 14. The iron saturation, so how many seats on the bus are filled, is only 4% of the available seats are filled. So when we have anemia, both of these numbers will tend to be low. The iron binding capacity is typically higher when we have deficiency, because again, we have a lot of availability. There's a lot of capacity for iron to bind. It's just not being bound. And then the ferritin, as we see these storage sites, is very low at 11. So is it possible that these labs could have had a ferritin low here at 11 and the iron be normal? Yes, we've already talked about the fact that ferritin, or the storage sites, can be deplete before we start to see labs reflecting low iron in the blood. The treatment of iron deficiency, first and foremost, find the cause. I tell people often, if you're not a heavy menstruating female, then there's another reason that you're losing iron or that you are not getting enough in. So we talk about diet, we talk about loss, we talk about, is there another reason? Should we do an endoscopy? Should we do a colonoscopy? Should we figure out if there's some sort of GI inflammation or bleed before we just start supplementing with iron because you're deficient? If somebody comes to me and say, I had a well-diverse diet, I don't have heavy menses, or is a male, or postmenopausal, then there's always going to be a little more digging that we need to do. Is it poor absorption? Is there, like I said, there's slow leak somewhere in the system? Or do we just need to supplement? So the very first thing we go to with supplementation is dietary. Can we get more of that heme iron in your system? Or do we need to use some natural medicines or supplementation? Some side effects of natural medicines or supplements include constipation and nausea. So sometimes that's not always the first route to go. A couple other less known ways to get iron into your system is to use cast iron skillets when you're cooking, and then to purchase something called a lucky iron fish, and that's on Amazon. And you actually put that into your food as you're cooking it, and it naturally will leach out iron into your food and increase your total iron content. You don't actually eat the fish. It just goes in the food as you're cooking it. Kind of a last resort, but often necessary, especially for someone who presents with labs like the ones I just showed, might be an IV iron infusion, which would require a referral either to an IV infusion source or to a hematologist or blood doctor. Does anybody have any questions so far in the lecture? I'm going to pause here for a moment and see if anybody wants to ask a question or have anything to add here. And have the chat window up as well. And we have one more person that jumped on here. Again, just to kind of go over, if you want to say something, you can unmute, feel free to chime in, ask a question. You can also use the chat window or raise your hand through Zoom, and I'm happy to pause. Everyone's doing good? Okay. We'll keep on. Oh, I'm sorry. How long does it take, so here's a question, to rebuild iron if one is a heavily menstruating woman? That's a really good question. To be honest, it depends on how deplete you are. If you're looking at labs like we just saw and you're very, very deplete, and every month you're essentially giving yourself phlebotomy with your heavy menses, then I might recommend an IV iron infusion and just bypass trying to get through the oral absorption and rebuild your stores and then maintain on oral supplementation from there. I've seen it be replete in as little as 3 months if we're really strict on avoiding the inhibition foods and supplements that inhibit the absorption of iron. If we can really focus on a high heme iron diet, using the cast iron fish and using oral supplementation. The second part of that question is, if you're a heavily menstruating female, then there's two things you need to think about. One of them is that's not normal. It might be familiar for you, but it's definitely not normal. So there could be another reason that your menses are abnormal, or we call that menorrhagic menstrual cycle. So very heavy bleeding. So I would definitely speak to your women's health provider or your primary care doctor about why your menstrual cycles are so heavy, and then also treat that either orally or through IV infusion. So calcium supplements, yes, are going to be the ones that are going to inhibit iron absorption more than just foods that have calcium in it. It's at a higher dose of pure calcium that can inhibit iron absorption. What in eggs blocks the iron? That's a really good question. I honestly don't know right offhand what the exact ingredient in eggs is. So hopefully that helps. Any other questions? Okay, we'll keep on going. Okay, so now I want to talk a little bit about iron overload. This is a condition that's a little more common than previously thought. And again, like I mentioned right at the beginning, why am I talking about iron? It's because I've been seeing discrepancies in iron homeostasis more often in my clinical practice. And the diagnosis of hemochromatosis continues to come up. And it was once considered much more rare in the population. And now we're seeing that it's actually much more common. Typically, it's diagnosed later in adulthood when the iron accumulation has gotten to the point where it's actually starting to cause oxidative stress on certain tissues that will then cause damage. My goal is that if we can run more preemptive labs because of some of these vague symptoms, we actually might be able to catch it earlier rather than later. Again, because it's diagnosed later in adulthood, it's typically over 40-year-old in males and not until postmenopausally in females, because again, monthly females are having their menstrual cycles and losing that blood. So it could be earlier if somebody is on oral contraceptives or has some sort of reason that they're not having menstrual cycles, but typically this is when we're diagnosing iron overload in our population. Genetic form of iron overload is the most common. This is called hemochromatosis, and it could be defined as hereditary hemochromatosis or just hemochromatosis. It typically affects what's called the HFE gene. However, not everybody who is positive for this mutation will have excess iron stores. We chatted about hepcidin earlier in the lecture, and it comes up here again because we have the genetic mutation in the HFE gene, which leads to a reduced hepcidin. And if you remember before, it's an inverse relationship. So reduced hepcidin will actually increase the intestinal absorption of heme and non-heme iron, but there won't be any feedback mechanism from there that's going to change the hepcidin regulation. So that's really where the pathophysiology comes in, and it's not well understood, but we just know that it's reducing the hepcidin to a level that we are having this nonstop increase in intestinal absorption, leading heme and non-heme iron to come into the system. This non-heme iron, this iron that is not bound to transference, once transferrin saturation is maxed out, right? Once all of the seats on the bus are taken, then the iron that's floating around in the bloodstream is actually oxidized. So it's reduced when it's inside the cell and it can perform its function. But when it's floating around without being bound to anything, it's in its oxidized form, and it actually creates oxidative stress when it's deposited in organs and tissue, and it can cause damage. The primary sites of tissue damage are the liver, heart, pituitary gland, and pancreas. Some of the symptoms of hemochromatosis are fatigue, lethargy, apathy, depression, skin hyperpigmentation or bronze color, joint pain or stiffness, symptoms of liver disease, weakness, diabetes, cognitive impairment or difficulty focusing, impotence, ECG abnormalities, immune dysfunction, and increased cancer risk. And if you think this sounds familiar to some of the vague, broad symptoms of iron deficiency, it does. That's why it's so important to run these labs and really determine what is the physiologic reason for some of these symptoms. I have a few patients that have come in and said, no one can find anything wrong with me. I don't know what's happening. I think I'm dying. I have heart failure. You know, all of these things are happening in my body and I don't know what's wrong. And well, I have diagnosed 2 people with hemochromatosis after one lab panel, started them on treatment, and things have improved. We really want to be earlier on in this process though, and get this iron and ferritin panel in earlier, because we don't want to be diagnosing somebody when they already have tissue damage from the excess iron in their system. Again, I don't want to wait until my 4th, 5th, 6th decade to be diagnosed with something that's causing me multiple organ inflammatory conditions. Here's an example of a lab that shows hemochromatosis. Again, this is one patient that I diagnosed after the very first lab. We did have to repeat them to verify, but again, you can see here's the iron. We have a lot of iron in the blood, not enough for diagnosis. Lots of the iron saturation. So the seats on the bus are full. It really should stay at about 1/3 full. That's the normal capacity that's found in the blood, but we're at 81% here. Again, the iron binding capacity is low. This one is showing normal, but it's always going to be on the lower end because there's less seats available on the bus to be bound with iron. Here's the big kicker. The ferritin was at 999. So we are just overloaded with iron. We see that the ferritin is overloaded, and we can tell, yes, this is more of an iron overload situation than a chronic inflammation type situation. A couple other key values that if you don't have an iron panel run on you and you don't have a ferritin run on you, but you have a complete blood count, which shows your white blood cells and your red blood cells. And I have a patient who comes to see me with these labs, and they have a good B12 and folate status, then this MCV and MCH, which shows me the cell volume, how big our cells are, when those are elevated like they are here, that can actually indicate either B12 or folate deficiency, or it can indicate an iron overload. So that right there, these two lab values that are often overlooked can be indicative of either nutrient deficiency or iron overload. And if we have a B12 folate level in the lab value as well, that can prove that's not it, then we can always add on an iron, and or we can check all of those nutrients. But there's other clues in the physiology in our labs and other labs that your providers are running that would indicate whether or not you're having some sort of iron dysregulation. The treatment of iron overload is phlebotomy. So if it is hemochromatosis and you have a genetic predisposition to absorbing more iron and keeping more iron in and not being able to downregulate that absorption level, then the treatment is phlebotomy, and that's essentially bloodletting. And how that works is you get your labs drawn, you get sent for phlebotomy, we redraw your labs and see what kind of impact that had. It's a little bit of a trial and error at the beginning to see how frequently you need to go to maintain that level without creating anemia, although it's always a risk to say, okay, if we do it too often, you can go anemic, but we know you're going to build back up until we find the right schedule that works for you. Every individual is different. Now, if you do have a certain case like I have right now, I have a menstruating female who was just recently diagnosed with hereditary hemochromatosis that is, again, still menstruating. So in that case, I don't necessarily need to jump to phlebotomy, right? We can utilize those inhibiting mechanisms, increase those foods in her system, decrease some of the heme and non-heme sources of iron, prescribe black tea and excess sweating, right? Let's exercise, let's get it out of your system, and let's retest and see if that has been adequate to relieve your body of the iron burden so it's not building up. Otherwise, we go to maybe a once or twice yearly phlebotomy schedule. So it's really individualized. It needs to be individualized, but really right now, that's the only actual treatment curatively for hereditary hemochromatosis. And then to manage the iron and the absorption, we just use the tools that we know can inhibit that absorption into the body. So that's really all I have for the lecture portion of the call today. So I'm going to open it up to questions. And hopefully you guys have some. Otherwise, we can break here in just a few minutes. And again, feel free to unmute yourself if you want. Otherwise, you can throw them in the chat box. Question, have I used Food from standard process to help deficiency? I can't on a Zoom call actually give medical advice as far as prescriptive wise, but I can say that I do use iron supplements to help with iron deficiency. I have prescribed those often. Of course. And on that note, if you have a specific question about a supplement that you're taking, or you want to ask a specific question about that, you can always send an email to our clinic at info@CDA Healing Arts, and then just put in the title, hey, open forum question, attention Karin Duncan, and our crew here, the staff up front, can take that question. Like I said, if you have a specific one about treatment, and they can forward that to me, I'd be happy to answer those questions for you. Does anybody else have any other questions? I'm not seeing anything come up in the chat box here. Anything else that you were hoping to learn from today's lecture about iron or lab values or what to look for? Okay, I'll give it about another 30 seconds and then we'll go ahead and sign off. This lecture will be posted to the website within the next couple of weeks for access to it. Hopefully you guys keep joining us at our open forums. This is something that we do here at the clinic for free, picking a topic, send feedback if there's a specific topic you do want to learn about, and then one of the doctors can take that on for a future session. Share it on Facebook, Instagram, let people in the community know that we're really reaching out, trying to educate and empower, especially in the times that we're in, to help our community heal and gather the information from trusted sources. So appreciate you guys all being here. And like I said, feel free to send your questions over to the clinic email address if you have anything specific from today's lecture or in general, and I'd be happy to answer those for you. Hopefully everybody has a great rest of your day and weekend and summer, and we'll chat with you soon.